Welcome to the Thyroid Stimulating Podcast. This podcast was created in partnership with the American Thyroid Association to discuss up-to-date diagnosis and management of a wide array of thyroid diseases. Back in 2023, we embarked on this podcasting journey with a focus on the emerging topic of T3 use for hypothyroidism. This has since gained mainstream recognition with the release of the new joint British Thyroid Association guidelines. So as we step into 2024, we are excited to be kicking off this year with our first episode, taking a deep dive into the intriguing debate between generic levothyroxine and brand name medication for thyroid hormone replacement. If you've ever wondered about the differences, the benefits, and the potential concerns when making this crucial choice, you've come to the right place. Our journey begins today by delving into the science behind levothyroxine and tracing the historical development of brand name thyroid medications. We'll then navigate through topics such as cost-effectiveness, availability, and potential variability in the medication quality between generic and brand name levothyroxines. Whether you're a healthcare professional, a patient managing thyroid-related diseases, or simply curious about the world of thyroid treatment, this episode is packed with valuable insights that you don't want to miss. Joining me today is Dr. Brito, a world-renowned thyroidologist and a leading authority on this subject, with over 200 publications in the field. Dr. Brito completed his medical training at Memorial Sloan Kettering on the East Coast and is joining us today from the Mayo Clinic, where he's currently a professor of endocrinology in the Department of Internal Medicine. Thank you, Dr. Brito. We're honored to have you as a guest on today's show.
Thank you very much for having me. I really appreciate the invitation and the opportunity to talk about this very interesting topic.
Okay, so let's get started. I wanted to start off today with a little bit of background on how levothyroxine works. If you can provide that information for our listeners.
Absolutely. So the levothyroxine is a medication used to treat thyroid problems, particularly an underactive thyroid gland problem, which is called hypothyroidism. So levothyroxine is the synthetic version of the hormone that we usually produce, which is called thyroxine. The hormone is very important for regulating your body metabolism. So when we take a levothyroxine pill, it enters in the bloodstream and eventually reaches our cells. Inside the cells, it turns into an active thyroid hormone. It's called T3 or liothyronine. This T3 or active form binds specific receptors in the cell, and by doing so will stimulate the activation of specific genes. These genes control how the cell uses energy, process nutrients, and perform vital functions. So as an end result, levothyroxine activates the metabolism. People produce more energy, generate more heat, and the cells become more efficient. So levothyroxine is really important to maintain the function of your body.
Thank you so much. Actually, I wanted to talk a little bit about the medication itself, in that you take it once a day, but it can last in your system a relatively long period of time. Can you go over a little bit about the metabolism of levothyroxine and the medication?
Absolutely. So the levothyroxine is, I believe, that has a very interesting way to be absorbed and metabolized. So once somebody takes the pill, it goes into the stomach, and that is the part that is very crucial for the absorption of the pill, because the majority of people take what is called tablet levothyroxine, and the acid production of the stomach will dissolve what is around the active component of the tablet, will dissolve that, and our gastrointestinal system will finally have the active form. It will pass to the small intestine and it will be absorbed. Once it's absorbed, it will stay in your system at least 6 to 7 days in average. And this is exactly why sometimes when we talk to patients about levothyroxine, we tend to tell it takes almost 4 to 6 weeks to actually see the effect of levothyroxine, because by adding on this medicine every day, eventually you reach a steady point in which finally you have what is called therapeutic levels. So it's one of those pills that you don't see the effect right away. You really need to take it at least daily for at least 4 to 6 weeks to have that particular therapeutic level. So it's other tricky thing about this, which is sometimes clinicians use it depending of clinical presentation, is since the absorption and the half-life of this medication is different, so it's not hours, it's days, you can take this pill in a weekly basis. We tend not to do that in clinical practice because there are some concerns of maybe people that might have heart conditions might see a significant increase or sudden increase. And we tend not to do that because it's also something patients tend to forget. So we have more experience with the daily dose, but in reality, we can also use this analogy or this benefit of very long half-life to do more alternative ways to take this medicine. Like taking just from Monday to Friday, or just to take it 6 times a week, and again, in some instances, to take it once a week. But again, the majority of times, it's a daily pill.
Okay, so I think knowing that information, I think when we're deciding between generic and brand name thyroid medication, we should probably talk a little bit about the history of how we got to where we are today, because I think that's an important avenue to discuss before we can move forward. So can you tell me a little bit about the history of brand name thyroid hormone? I know it's a very interesting story, so I want to share this with our listeners today.
Absolutely. So everything we need to talk about the history of levothyroxine. We are gonna talk about the history of thyroid replacement. So a long time ago, around 1891, doctors actually used a substance from the sheep thyroid to help people with thyroid problems. So they desiccated these thyroids. They made it dry, powdered them, and they give patients that have no thyroid and they were quite sick. And it was very effective. In 1914, scientists actually discovered the substance within the thyroid that was responsible for the effect, which the thyroxine. They figured out how to make this thyroxine in around 1926, and they started making it in the labs. By 1962, they already have in the market the synthetic levothyroxine. And around that time, we had actually the first brand name levothyroxine, Synthroid. What is very interesting is that despite having levothyroxine synthetic available in the market, people were most often treated with the desiccated form of thyroid hormone, the one that came from animals. And they continued that treatment as the preferred treatment regimen until 1970. In 1970, things changed for 2 reasons. The first reason is the implementation of the TSH assay. So by doing more TSH assay in the practice, there were some realization that patients taking these desiccated thyroid extracts were probably taking too much thyroid hormone. And the second thing that happens in 1970 is that it was understood that thyroxine, or what is called T4, turned into the active form T3 in the cells. So that made some people believe that you don't really need to take these extracts that were a combination of T4 and T3, rather you can be okay by taking just T4. And then more people were switching to the monotherapy with levothyroxine. Then in between 1917 and 1997, there were some concerns about how the medicine was made, the brand and some generics that were already in the market too. There were mostly concerns about the consistency and the strength. And due to those some concerns, the FDA around 2000 decided that any medicine, brand or generic, had to have an approval to be again available in the market. In the past, FDA did not require this what is called new drug approval process because it was understood that levothyroxine It was not something new. People had been using thyroid extracts for decades. So at that time, in the 60s, 70s, and 80s, FDA did not really require it. But due to these concerns of strength, content, FDA decided that it's time to get a more formal process. So in 2004, FDA actually approved the first generic, and there was a lot of concern in the community, in the thyroid community, that the process by which the FDA assess the bioequivalence of this generic compared to brand was not ideal. Particularly, they were concerned that the marker that was used to assess therapeutic equivalence was T4, which is the levels of that hormone in the blood, rather than TSH. And in the field of thyroidology, we tend to rely much more in TSH because it's a really good reflection of the amount of thyroid hormone that is in the bloodstream. Due to this and other concerns, the several societies put forward some guidelines about this. They were really concerned that generic was not the same as brand. They did not say that brand was better, but they were concerned that if you were taking brand or taking generic, and then you switch to another product, that other product might have a different amount of levothyroxine or might be absorbed differently, and as such, might have an impact on the thyroid levels. And the main thing here is because one might ask, but that is a decision made by the clinician, why they are concerned about switching, is that in the United States, the switching among generic products is actually authorized at the pharmacy level. So clinicians, we don't get to decide if you were to prescribe a generic levothyroxine. You don't get to choose the same product, the same generic every time. So patients can be switched at the pharmacy level across different generics. So the only way to keep a patient in the same product became to keep patients in the same brand, because brand is something that we can control at the clinic level. So given this potential problem of switching different products, what the guidelines suggested is that if there is a switch between from brand to generic, or if you are taking generic, you might need to test thyroid hormone values more often because you might have an abnormal level caused by, again, switching to a product that have a different content. So that is how we ended up with this significant problem at the level of healthcare system, at the level of the clinics, patients, clinicians, guidelines, of really not knowing whether patients will benefit of taking only brand or generic.
So these guidelines that came out that had suggested of taking brand name preferably over generic weren't necessarily saying that brand name is superior. They were just more focusing on switching between different generics. Can you talk a little bit about what the differences between the brand name and the generic would be? Not necessarily that one's superior, but what differences kind of exist between them?
No, absolutely. And you're right. So it was not that the guidelines was saying that brand is better. They were just concerned that if you are taking generic, you're just going to be at risk of being switched without knowing. And if you're taking brand, if you switch, there might be a problem of thyroid hormone values. So you're absolutely right. The guidelines did not really endorsed on a brand versus generic, but the practical implications of that recommendation was that some clinicians actually decided to avoid that problem to keep the patients in brand. So what are the differences between brand and generic? So the brand name medications are the original medications developed by the pharmaceutical companies. So they are marketed by the pharmaceutical companies. They usually go extensive research, clinical trials. They prove the safety, efficacy, and these medicines are well used. And once the patent expires, other companies can produce the same medicine, the same active product, and they are called generic versions. And the generic versions must meet the same quality and safety standards as the brand name. So brand and generic have the same active ingredient. So they have the same amount of levothyroxine. What might be an important difference is that they have not always have the same inactive ingredients. So when you have a tablet of a medicine, like for instance, levothyroxine sodium, which is a generic, or Synthroid, which is a brand, they have the active product, but they also have inactive ingredients. So these inactive ingredients can be lactose, sugar, dyes, many other things. So when you have a generic, they might have the same amount of active hormones, but they might have different inactive ingredients. So that becomes the main difference between brand and generic. Both, however, when they are in the market, have to follow the same quality standards already implemented by the FDA.
Okay, so I just want to summarize for our listeners that if it says 100 micrograms of levothyroxine, whether you're taking the generic or the brand name, you're going to have the 100 micrograms. So that's the active ingredients of the levothyroxine. And this is because of the FDA ruling in the early 2000s to ensure that even in generic, the active ingredient is going to be the same amount. With the inactive ingredients, such as the dyes and the fillers, are what's different. So there are different brands out there, including Synthroid, but there's other brands that have liquid thyroid hormone, gel thyroid hormone. Can you talk a little bit about those?
Yeah, absolutely. I think those ones have been in the market for more than 1 decade now in the brand form. So the Thyroid and this gel capsule, and there is a solution, meaning just liquid. So what is the main difference? Is that Synthroid, for instance, is a tablet. The Thyroid capsule is actually a dissolved levothyroxine in a gel kind of a capsule. So they don't have fillers, or they don't have a lot of these inactive ingredients. It's just very simple. And the other one, which is the solution, is pretty much just the active hormone, and that is dissolved in a little bit of water in a glass, and people can take it directly. So these two other ones, we tend not to use that often in practice because they might have a specific use. Well, for instance, people who might have some gastrointestinal problems and they might have some absorption issues, people might try these capsules or solutions. And the main rationale behind that is that you really need to have acid in your stomach to dissolve the tablet to release the active ingredient. So there are many people that might not have this amount of acidity in the stomach. So people who probably have surgery in the stomach, people with several conditions, autoimmune problems in the stomach, or many medications that can interfere this. So there are a subgroup of patients that sometimes in practice we do consider switching from tablet to capsules or to solutions. Now, the reason why I'm saying that is not often used in practice or very randomly used in practice is that you can actually overcome some of the issues of absorption at the level of the stomach and gastrointestinal absorptions by increasing artificially the dose of tablet. So you know that in somebody 100 micrograms might work, and somebody that is also the same weight but might have some gastrointestinal problems, you can actually try 100. It doesn't work. You keep adding additional doses until you see the numbers reaching the normal values. But that is the main difference. I think it's just the absence of inactive ingredients in the capsule and in solution compared to tablets.
Is there any risk of increasing the dose to just go higher for these patients? Is there any concern for hyperthyroidism or any other side effects with doing that?
Well, if done correctly, it's unlikely. What is correctly is first to make sure that the medicine is taken right. So your clinician might advise to take tablet levothyroxine at least 30 minutes before breakfast. The idea behind that is that anything that has calcium, for instance, will impair the absorption of levothyroxine tablet or even levothyroxine capsules or solutions, because it will bind a little bit of the thyroid or the active form and will not let it absorb. But if you take it correctly, 30 minutes before the first meal, and then the levels are checked 6 to 8 weeks after the change of the dose, it should be very safe to see where you land and maybe make additional changes based on that. So if you go and follow your clinician's guidelines from primary care or endocrinologists, it's quite likely that the titration is safe.
Okay, that's great information to know. Looking at the research, are there any clinical studies that compare the effectiveness of generic versus brand? And on the topic of switching, I know you personally have done some research looking at what happens if you switch between brand and generic versus generic and generic. Can you discuss that a little bit?
Yeah, absolutely. So our team, about 6 to 8 years ago, embarked in a series of studies to really understand the consequences of this recommendation by guideline. And one of the first studies we did is to really see how often brand versus generic levothyroxine was used. So there were a lot of speculation about people using more generic or more brand. We really wanted to see that. So we use a very large data set in the United States, almost 130 million individuals in this data set. So within this large population, we just want to see what people were using. And what we noticed is that overall, there was a trend towards less use of brand over generic. So people were using less brand over time, and people were using more generic, which is a very typical thing to see once a generic comes to the market. What is interesting, what was very interesting in that study was that when we look at the specific subgroups, people, for instance, when the prescription was given by endocrinologists versus other specialties, we noticed that the endocrinologist is a subgroup in which brand use was still very high, while in other subgroups, generic use was almost in every 10 patients, 9 getting generic over 1 getting brand. For endocrinologists was almost out of 10 people, 3 getting brand, 7 generic. So was the only subgroup in which we found that brand therapy continues to be quite relevant. And that makes sense because it's endocrinologists the ones actually reading the guidelines that we were talking before. So after seeing that, we started in the subsequent experiment. It was a comparative effectiveness. So we were comparing 2 ways to treat patients, again using this big data. And we were comparing individuals who never received levothyroxine, but they were to start on brand. So they started in brand. And another group, very similar for every aspect that we can think of, except that it started in generic. So very similar groups, very similar TSH values. And we just follow these patients observationally in 3 months, and we reassess the thyroid levels. And the thyroid levels were exactly the same, whether you started brand and you started generic, which is actually consistent with the guidelines say that brand is not better than generic. So either you start on brand, or either you start in generic, in 3 months, you will get very similar values. And then we follow these patients for a couple of years, patients that were just on brand, patients that were on generic. And after 2 years, we did not see any signal of concern, meaning that patients taking brand or generic did not have higher risk of cardiovascular outcomes or breaking a bone, which is our typical things that we think of if you were over-treated, for instance, with levothyroxine. So we did not see a significant harm in the long term if you were only to be taking generic or if you were only to be taken in brand. But the big question continued to remain. What happens among those patients taking generic, and what happens with the switchers? So then we did another study to really understand if switching actually happened, because remember, this is just at least ideas that we think of people switch all the time at the pharmacy levels, but nobody has actually looked at this. So we went and did a study, 500,000 people in this big data set. And we noticed that within 1 year of starting levothyroxine, at least one of the three manufacturers of generic levothyroxine in the United States, 1 in 4 people will switch, and of course without knowing, to another generic levothyroxine. So switching does happen in about 25% of the population. And the most important factor associated with switching was how many number of pharmacies patients used to fill levothyroxine. So we realized that if you were a patient getting generic levothyroxine and you go to one time to fill it in this pharmacy and then you go to another pharmacy to fill the second prescription, it is more likely that you get another product, which makes sense. But then we did, again, another comparative effect in the study, this time comparing individuals taking generic levothyroxine, and they continue with the same product. And patients compared to patients taking generic levothyroxine and switch to another product. And since this is something that is done at pharmacy level, we realized that it's the closest that we can get to a randomized clinical trial because the allocation, meaning where people are studied for each group, is really random. It's not like we clinicians force people to take a specific generic, nor like the pharmacists will choose the patients that they will give a specific generic. It's just a very random thing that you get one generic versus another one. So that particular study design allowed us to get very robust conclusions, which were that regardless of where you same generic levothyroxine manufactured, same product, or whether you switch, the thyroid levels were the same at 3 months and were the same at 12 months. And this last study completely contradicts the concern that switching will cause a significant thyroid level problem or increase that will have any clinical consequence. Now, big caveats about these studies is that the majority of the population here were taking lower doses of levothyroxine, about 50 micrograms daily, which is what the majority of people in the United States take. So the majority of people in the United States actually taking a very low dose of levothyroxine. The majority of these individuals were not patients that were taking 150, 200 that sometimes we get to see in the clinic, and nor they were patients with thyroid cancer. So we did a subgroup analysis of patients with thyroid cancer. We did not see a difference, but also the sample size was extremely small, which limits the ability of us concluding that that we are confident about that result.
Thank you for sharing the results of your study. So it seems to me almost a misconception that we had that, the switching generics might lead to changes in absorption or changes in your TSH levels. Are there any other misconceptions or myths that you feel are out there regarding generic versus brand name medication for Hashimoto's?
Well, I think the big misconception is that being generic cheaper drug, I think we have this as a part of how we think that cheaper is bad or that the more expensive is better. I think the majority of requests for brand actually comes from the patients themselves asking for brand because I think they feel like they are getting a better product, when in reality, again, for the most part, there will not be any difference whatsoever if they just get generic. So I think the big misconception there is that. There is another idea that sometimes even clinicians and patients have is that some of the brand products, they don't have the same kind of inactive ingredients that the generic has. So the people say, but this brand product might have less harmful inactive ingredients. It's not the case. Again, this is usually very well regulated by the FDA, and the majority of these inactive ingredients are completely inactive. They don't cause any harm. Some patients get concerned about gluten sensitivity, and certainly the amount of gluten on these tablets is none or minimal. And or people get concerns about lactose problems. Sometimes these inactive ingredients might have a lactose, but the amount of lactose or even the amount of gluten or any other important factor, inactive ingredient is really in very small amounts. So I will say that is not well funded. The idea that these inactive ingredients have significant repercussions on how the patients feel.
Speaking of inactive ingredients in the thyroid medicine, one of the questions that I get is what is the point of them and why are they there, right? Like, so who decides what gets in and what is the purpose of having the inactive ingredients?
No, yeah, that's a good question. So the inactive ingredients, for instance, in the tablets, is just to release, to protect the active ingredient until it reaches the right places. So the active ingredient being the levothyroxine, the inactive ingredient is just the filler of that particular tablet that gets dissolved, meaning gets destroyed in the stomach. So the active ingredient is released. And by doing that, also gives some stability, to the content of the pill, the content of the active ingredient. Now, you can achieve the same degree of content in the amount of active ingredient by just doing, again, the capsule. So the capsule, for instance, doesn't have any inactive ingredient, but you are not supposed to chew. You're supposed to swallow, because the moment that gets dissolved in your mouth, for instance, it will be a problem of absorption. People can actually absorb a little bit of levothyroxine in the mouth. So one of the reasons, for instance, that Thyroxine, the solution, needs to be taken with water right away is because if you just squish it in your mouth, it can be absorbed a little bit there. And levothyroxine is actually sodium levothyroxine, and might, to some patients, irritate the mucosa from the mouth. And there are some cases in which patients don't do it correctly. They might absorb some, it's not ideal. They might absorb some in the mouth, and they can cause a little bit of irritation. So these fillers actually protect you and protect the active ingredient to be released at the right time when it gets the small intestine.
Thank you for sharing that. I feel like people need a reminder that they're there for a reason. And it's good that, that their job is to protect it, and they have very minimal side effects for patients. Speaking of which, for your patients, what do you consider key reasons to choose generic or brand name? Is it just patient preference, or are there more reasons why you might choose one or the other?
For 99% of my patients, this is not really a conversation. The majority of them are completely okay with whatever we choose. And again, for them, we always go with the default of being generic. So it's not really, I don't remember having a conversation in which this was really the core of the discussion. But, there is always patients that have very interesting questions about why brand or why generic. So I used to tell the story of how we reached to that problem. There is a specific subgroup of patients, though, that I don't think we have yet enough evidence. And going back to my caveats from the studies that we conducted, is that when you give a patient 50 micrograms of levothyroxine, you're pretty much giving a small amount in a patient that still has what is called thyroid reserves, meaning it still has a good amount of levothyroxine running in their bloodstream, produced by their own thyroid, despite having Hashimoto's thyroiditis and things like that. So they still have thyroid reserves. We have not been able to do the study among patients who actually have no thyroid. So patients who might have big nodules, cancers, that take the thyroid out, and they don't have thyroid reserves. In those individuals, any signal that can come from different absorption or different content between generic and brand should be magnified, because there is no thyroid reserves that can actually modulate any potential difference. So it is important to notice that if that particular subgroup we still do not know, it's quite likely that it's not a true difference, but the limitations of the studies that we have done are obvious that for this subgroup, we don't have enough evidence. So what I'm saying this is because if I have a patient that has no thyroid and is telling me that she or he can tell, or they can tell the difference when they are on brand, when they are on generic, and they feel better, and I see the numbers not being usually consistent, I might go with brand if I think that is a true a potential patient that indeed there is some degree of difference. Again, 1 in 100 perhaps, but the majority of patients, it's a straightforward prescription with not a lot of questions. Actually, patients feel much better knowing that they have to pay only $10 as opposed to the significant amount that brand therapy costs.
So I think that's actually kind of two interesting points that are brought up. The first one that I wanted to actually talk about is the role of the patient in this decision-making process. So there are definitely some people, even in my own practice, that swear that brand name thyroid hormone, if they don't have that, that they don't do as well for generic, right? So for those patients, I do think that there is a role for brand name. Partly maybe it's a placebo effect. Maybe it's something else about them that we haven't discovered scientifically yet. But I think that's a kind of an important consideration that we should take that into patient preference into consideration. But that leads me to my second question for you, actually, is that, you mentioned that it was kind of a myth that just because brand name is more expensive, it's better. But how much does cost play a factor in you deciding, or even your patients deciding on whether to choose brand name or generic?
I think this is very good questions. So things have to change. So I think the patients are just perpetuating what they are reading. And if the best information is coming from the guidelines continue to say this. So there is not really, nobody's surprised that patients are coming up with these questions but the guidelines is saying that if I am taking generic, I'm more likely to be switched, and there might be some inconsistency. So I think the patients clearly have a strong argument to have these conversations. But then again, the new evidence is probably going to, hopefully, the new guidelines will take this into consideration. Once the guidelines take this into consideration, perhaps the same societies can disseminate this information across patient groups or other society to trying to reach the majority of individuals taking levothyroxine and give some peace of mind that the majority of them will be okay with generic. But again, you are absolutely right. So if a patient comes and clearly I can see a trend that while using brand is different than generic, that there are some evidence in the labs that tell me that while brand is better, while taking generic is not, yeah, that makes absolutely sense, and we can switch to brand and reassess. Now, I think the challenges with always bringing that conversation to patients, meaning every time that a patient is being treated for hypothyroidism, talking about brand or generic, I will not advise, because this is why we have FDA. So this is a population-based intervention that has been already vetted by an organization that is telling us that the pill is equally effective. So what I tend to spend more time on is, how to take it well, what to avoid, because the majority of patients that suffer some symptoms, they don't suffer because brand or generic, they suffer because they are not taking it well, they're usually take it with coffee, they don't wait the 30 minutes. In fact, some studies suggest that almost 1 or 2 out of 3 patients, they don't take it correctly, or they take it inconsistently in a way that clearly affects thyroid levels. So there are more important things, I believe, that we have to spend more time rather than talking about brand generic. My recommendation is to start by default with generic, and then, of course, reassess in the future. And as you said, of course, always hearing what the patients have to say. And if there are these pages in which they clearly tell the story about brand or generic, being open-minded that they may be better with brand.
Yes, so I totally agree with you that consistency in taking the medication the same way and avoiding any sort of interactive other medications or food or coffee is more important than the generic versus the brand debate. So thank you for sharing all of that information with us today. For our listeners, can you give us like 3 takeaway points that you think are kind of important for when choosing brand name versus generic or having this discussion with patients?
Yes, my first take-home point will be generic is as good as brand in the majority of patients. It's cheaper. It has been already vetted. It has been going through many important evaluation studies at the FDA level, and certainly will save a lot of money, not just to your patients, but to the healthcare system. It has been estimated that patients on brand, for instance, particularly when there is out of pocket, might be in the expense of $500 to $700 extra per year. So it's for somebody that lives paycheck for paycheck, is a significant expense. So it's not only in case I get better with generic or brand, is really an issue of taking expensive drug that might not bring additional benefit. So my suggestion that is mostly to my colleagues endocrinologists who are the majority prescribing brand is to reconsider whether there is any true benefit from that, and perhaps start using as a default levothyroxine generic.
Thank you for joining us in today's episode of the Thyroid Stimulating Podcast. While the debate between brand name and generic thyroid hormone replacement continues, it's crucial for patients to work closely with their healthcare providers to find the best option for their individual needs. Factors such as consistency, reliability, and affordability all play a role in this decision-making process. We're grateful to have had Dr. Brito as our guest speaker, providing valuable insights and expertise on this complex topic. As we wrap up this episode, we're excited to announce that our upcoming episode will delve into the fascinating topic of microwave ablation for thyroid nodules. We'll explore how this innovative procedure offers a minimally invasive alternative to surgery. Stay tuned for more insights and expert opinions on this cutting-edge treatment option.